So, RDS, formerly known as hyaline membrane disease, BPD, such were a pathological diagnosis which were there, which were changed to more of physiological or clinical diagnosis later on. So, hyaline membrane means you have a eosinophilic hyaline membrane inside the lungs in the alveoli, so which you can never demonstrate clinically. You don't do autopsy or histopathology for lungs for RDS. So very pertinently, it was changed to RDS. RDS refers to any baby with respiratory distress. So can meconium aspirations as RDS as well? Probably not. And can TTNB should now be called RDS itself? So probably yes, but RDS is more of a baby who has respiratory distress, is preterms, and whose chest X-ray is suggestive of, say, a disease called hyaline membrane disease, which is characterized by ground glass appearance, air bronchograms, reticulogranular pattern. So RDS is a typical entity in it, and but that this thing for PGs, remember that RDS is an entity in itself. It should not be used as a generalized term for any baby with distress. RDS most common cause of respiratory distress in preterm infants because lung immaturity is associated with inadequate production of pulmonary surfactant. Incidence of RDS increases with decreasing gestation age and infants born below 30 weeks at maximum. All babies under 28 weeks to 30 weeks may have some element of RDS. If RDS doesn't require or distress doesn't require respiratory support, doesn't mean that presence the kidney itself would qualify to have a baby with RDS if he has some signs on chest X-rays to suggest the same as well. Diagnosis of RDS is mostly clinical. You don't require an X-ray to prove it. But yes, X-ray is a supportive diagnosis because there are numerous respiratory distress which could be there. So if we want to the causes of distress, they can be classified into pulmonary causes and non-pulmonary to begin with. And pulmonary causes could be like RDS as well, ADHD, another, dyspnea, another. Could be classified in preterm is asphyxia lung injury in baby with history that would be there. Meconium aspiration syndrome in a baby who is there. So um, this is what causes of RDS as respiratory causes are to be all. It could be PD, it could be I, with pneumothorax, and so all that is yes, and other mass lesions can be there. Uh, I at least 5 or 7 times I have thought the baby has RDS, given him surfactant out that he doesn't have surfactant deficiency. He has actually a mediastinal mass or something else which is causing the white lung. X-ray is diagnostic most of the time, and one has to be very keen observer. But this cannot be missed. You can see almost a white out lung with good air bronchograms are here going right to the periphery. Beyond the primary bronchus, if you can see, um, this arc hollow structures, then they are said to be. And especially if they are going beyond the cardiac borders, like this one is going beyond the cardiac borders, especially in the left upper zone. RDS is again a more of a homogeneous disease. You can see both lungs are almost symmetrically affected, left and right side, upper and lower zones. Unlike, say, meconium aspiration or a pneumonia, which is more likely to be a heterogeneous disorder. Biochemical tests. Biochemical test, earlier LS ratio used to be done, and the shake test can be done, but they are hardly ever done now, and we should not waste our time in that. Um, most probably it can, but for postgraduate students, MBBS students, it can come as a question, and one needs to know what is shake test and when is it done, and what is LS ratio. LS ratio is something which you check antenatally, whereas shake test is something which you do postnatally. So these are some X-rays with RDS again. You can see this preterm baby. This one has, you know, right, left side is relatively better. This would be baby who is on CPAP. So a baby who's on CPAP will have an X-ray after, this is the era of delivery room CPAP. The baby could be sat on CPAP in the delivery room itself, and by the time the baby is in the ICU and X-ray is ordered and the X-ray technician comes over, it could be about half an hour to 1 hour in a baby in whom it's not an emergency. So lungs could be reasonably expanded because of the CPAP, and so that classical HMD pattern on X-ray may not be visible in moderate babies, especially 32 weekers. And and the right is the classical RDS with the whiteout lungs and reticulogranule pattern is visible in the air bronchogram extending beyond the you can say the cardiac shadows is observed. Management begins before birth. Interventions to prevent RDS and improve outcome can begin before birth, even if preterm delivery cannot be prevented. Um, so, what do you do for such babies? You give antenatal steroids, and so antenatal steroids is a very important drug which can be given. It should be administered to all pregnant females 23 to 34 weeks who are at increased risk of preterm delivery within the next 7 days. Case of prenatal antibiotics can delay the delivery and reduce neonatal morbidity, including made for surfactant or coamoxiclav should be avoided. Magnesium sulfate given to mothers with imminent preterm delivery markedly reduces cerebral palsy and incidence of seizures. A baby who is quite preterm and expected to have significant RDS should best be transferred in utero. All in utero transfers, all preterm births before 30 weeks should ideally happen at a center where neonatal care is possible. So all 30 weeks, baby should not be delivered at a peripheral obstetric center and referred to NICU. But they should be brought to, if you have perinatal services in that NICU, then preferably mother should be shipped. Care right at birth may be vital because the sedation, etc., are very important in expert hands. If ex utero transport, it is best done with the incubator and trained staff, trained doctor who can transport and take decisions and actions while on the way as well. So this is very important that during transportation problems can arise and transportation has to be in safe hands. However, consent for some mishap during transportation should be there because such sick babies can hold their breath, can develop pneumothorax because roads are not the best in the country at times, and some bumpy rides can happen, which can lead to extubation, accidental extubation, which can lead to uh, pressures going in, and monitors may not be, having good skin contact with the between the skin and the monitor, so it may not be showing the desaturations very consistently. So these are the practical problems which can be seen at times, and one should be cautious for them. You need double and handheld pulse oximeter. So syringe pumps and all should be there for transportation of this baby. Management of RDS, specific interventions that include adequate oxygenation and ventilation, and possible administration of exogenous surfactant. These are specific interventions, but general supportive care is what will save this baby most of the times. You need to optimize infant's metabolic and cardiorespiratory status, like correct his hypoglycemia, which is there, start IV fluids, and temperature regulation is to be normalized. Many babies, while being transported in hospital itself from OT or delivery room to NICU, may become cold and hypothermic, especially if not transported in transport incubator. Even if while being transported in transport incubator, babies still may become hypothermic. So maintaining hypothermia, euthermia, euglycemia, eucalcemia, they are very important. And then antibiotic specific interventions focus on preventing or decreasing severity of RDS. And we have gone through administration of antenatal steroids, which is better, Dexa or Beta. In India, Dexa is recommended most often, and but whichever is available can be used. Oxygen therapy is the initial treatment which one gives. Provision of positive airway pressure to prevent atelectasis can be there, and exogenous surfactant therapy. These are the three cornerstones of treatment of RDS or respiratory support which we have to offer. Aim of management of RDS is to provide interventions that maximize survival while minimizing potential adverse effects, including the risk of BPD. How do we deliver oxygen to babies with RDS? Nasal cannula is to be used, and gone are the days for using head box oxygen, which used to give about 3 to 5 liters of oxygen had to be given through them for RDS, and they are to be mentioned only to be discouraged for usage, only to be condemned that they should not be used. Not only a lot of oxygen is given to the baby, but also wastage for the unit is there. And so a lot more cylinders are used if you use head box oxygen as compared to say nasal cannula. You have to give very low flows, 0.5 to 1 liters per minute of oxygen, and maximum to maximum you can give 2 liters per minute. Most often, no humidification is required for nasal cannula. Also, the water traps which used to have saline or distilled water, that is also not recommended to be used now. And dry water traps are used nowadays to deliver oxygen by nasal cannula. Oxygen concentration depends upon flow rate, weight of newborn, and respiratory rate of newborns. So for a 1.5 kg, 0.5 liters give about 30% oxygen. So it is not 100% which is going through nasal bronchs. So 1.5 kg, you give half a liter, 30%, and you give 1 liters, it is about 60 to 70%. For 2 kg, again 60% and 30%. So 30, 60, 30, 75, this is all what you can remember. And for a 3 kg, this half liter will give 25 and 1 liter will give double of about 50. So you double the flow and double the FiO2 roughly. This is what can be remembered. Well, if you have to answer MCQ, then you have to be exact, and then for weight, these are the numbers which are there. But for clinical practice, half liter is about 25 to 30%, and 1 liter gives about 45 to 70%, depending on the weight. Now, flow chart for use of oxygen therapy. If the baby has hypoxia or respiratory difficulty, start oxygen by nasal cannula of 0.5 to 1 liters per minute. If SpO2 is less than 91, increase flow up to maximum of 2 liters per minute. Consider oxygen hood if you don't have any other advanced facility at your center before you can refer. And if there is no improvement with this, then you start CPAP, HHFNC ventilation. Now, there is another school of thought which says that any baby with distress, don't give oxygen at all and just immediately begin CPAP. So if we are want of CPAP and respiratory support apparatus, that is, we have less in number, then you give oxygen. If you have ample CPAP, if your workload is less and you have, then it is good for all preterm babies with any distress to begin CPAP directly, can be the standard of care. But we live in an impoverished country. Opening up of a CPAP would mean opening a new, what do you call it, the whole apparatus for CPAP. The cost may there in government facilities, they may not be readily available. So you can begin with oxygen and move on to CPAP. So nothing is absolutely generalized to all day. You have to individualize based on degree of distress, based on oxygen requirement, based on facilities available at your site. Will it be medico-legally or medico-ethically incorrect to not start CPAP and give only oxygen to such babies? So the answer is no. You can't be sued for giving oxygen to a baby who has mild distress, and that is the reason why generalizable guidelines should be there. If your saturations are between 91 to 95%, monitor clinically and look at the saturations. Clinical monitoring is very important. It just can't be based on the monitor, but how is the degree of distress that has to be seen all the time. If there is clinical deterioration, that is distress is increasing, how do you monitor distress, objectively? You need to do Downey score or DVM score, Downey's and Vidyasagar Morrison score as it was called, DVM scoring, Silverman scoring. These are two very important methods to monitor. Look at the or hear the grunt. If grunt is there on oxygen, he definitely needs a CPAP urgently. Grunting is a sign of advanced respiratory distress, especially if it is audible grunt without auscultation. Then such babies they do require CPAP definitely. If SpO2 is more than 95, you can start giving FiO2 or your oxygen. Whereas if it is less than 91, you need to upgrade. So do's and don'ts of oxygen therapy. Oxygen therapy is a drug. It should always be given in monitored situation and monitor oxygen saturation using a pulse oximeter. All babies on oxygen should have pulse oximeter attached to it with the alarm limits of about 90 to 95% in preterms, and it could be higher in term babies. Administer oxygen if SpO2 is less than 91. Saturation targets is 90 to 95 or 91 to 95. If your targets are low, say 88 to 93, 88 to 91, your ROP incidences may come down a bit, but mortality tends to decrease a little bit. So there is a trade-off between giving low oxygen monitor, uh, low oxygen target saturations between, say, better ROP but higher mortality. Nasal cannula is the preferred mode of oxygen delivery for sure. Do not give empiric oxygen to all sick newborns. Do not give oxygen flow of more than 2 liters by nasal prongs. Do not use oxygen hood without regulating the FiO2. Do not use head box with flow rate less than 2 to 3 liters per minute. So if you have to use, say, this oxygen hood, you have no other means to give oxygen, then you need to give it at 5 liter plus. Um, so the final points on oxygen is a drug which is life-saving, but it can also be toxic. The whole saga of ROP, which has been, monstrous ROP, as we can say, which a disease which potentially makes a child blind and which has large medical legal implications for a baby, for a family and doctor as well. So this all can be minimized, not all, but most can be minimized by giving very judicious oxygen therapy. All neonates on oxygen should be clinically monitored and continuous pulse oximetry should be there. Low flow oxygen cannula should be used. CPAP or HFNC can be required if neonate have persistent moderate to severe retractions or apnea or hypoxia despite maximum permissible oxygen by hood of nasal cannula. Um, Initial management in the delivery room assisted. So once you fail oxygen therapy, that is failure of oxygen therapy would mean increasing Downey score, increasing Silverman score, and decreasing saturations despite your increasing flow rates. That would mean failed oxygen therapy. You don't have to waste much time on oxygen. You can diagnose failed oxygen therapy in 5 minutes, 10 minutes, 15 minutes of time. and go on rapidly to start CPAP. If your initial Silverman score are 6 or 7, then you need not waste time by starting oxygen at all, and you should immediately begin respiratory support by CPAP or HFNC. So, um, I would rather directly go on to non-invasive ventilation for failed oxygen therapy. How early do you begin non-invasive ventilation? Non-invasive ventilation can begin directly in the delivery room itself. You don't have to have the baby in an ICU before you can begin CPAP. So management is based on infant's respiratory status immediately after delivery. If you see the NRP protocol, the 2026 protocol, after the initial steps and assessment of respiration, you look at if respiration is good and look for respiratory distress. If distress is there, you immediately start non-invasive ventilation, CPAP. So within 90 seconds to 120 seconds, you can actually be on CPAP as per your latest NRP guidelines. So respiratory distress, but with strong respiratory time. This is important. A baby who has apnea cannot be started on CPAP. He needs to have strong respiratory drive for uh, tolerating CPAP. So baby who has had asphyxia may not be the best candidate for CPAP because his respiratory drive may be poor. Apneic or need for significant resuscitation of babies less than 28 weeks, especially who has not received any anti-antal steroid. If you have bad cord pH, then you may consider direct intubation and ventilation, though there are no standard rules for this as well. And most babies who require resuscitation have cord pH of say 7.0, base excess of -15. Most people would prefer to give directly intubate and shift the baby on intubation, stabilize the baby, give surfactant, have X-ray, have that gas is better, and before you extubate and start CPAP. So there are no rules as such, blind rules. ये है so AI may not be the best policy at this time that check this and do this, check this and do this. Just a moment. Hello. Webinar, online lecture. And respiratory support that prevents and reduces atelectasis should be administered to all preterms who are at risk of RDS or who are having RDS. Give FRC by keeping alveoli distended in both inspiration and expiration. So, what does the respiratory support do? It gives functional residual capacity so as to keep the alveoli distended and having good ventilation perfusion um, ratio. So ventilation perfusion mismatch should not be there. If alveoli is distended and blood flow is good, the VQ mismatch is there. If your blood flow is poor, say after asphyxia and cardiac insult, and but your lungs are inflated because of good resuscitation, again VQ mismatch is there. So giving the functional treatment of RDS is giving FRC. So have the lung alveoli distended both during inspiration and during expiration. Non-invasive ventilation is the preferred modality to provide PEEP. Limited data suggests NIPPV may be reasonable alternative to a nasal CPAP. HFNC or heated, humidified, high flow oxygen is the third modality which is there, and it is good for babies who are more than 30 weeks of gestation. Now, one missing link which has been left out over here is once you admit a baby with distress, do you just start, say, interventions like CPAP and oxygen? Most of us will be doing some investigations as well. And I would just outline the investigation. So, all such babies would require, say, a CBC, look at your hemoglobins, TLC, platelets. You would require CRP at birth. Most people will not do unless there is a history of, say, PPROM, unless there is history of prolonged oligohydramnios. So otherwise, most people will do CRP only at 12 to 24 hours. PCT or interleukin can be done earlier if you have high index of suspicion for sepsis. foul smelling liquor is there, and so that we have to individualize every time. CBC, CRP, blood gas, X-ray. If the baby has been quite hypoxic, needing resuscitation, PT-INR also may be required. So these are the baseline tests. Shake test in which you pull out the gastric aspirate and you shake it in a test tube and look at the number of bubbles in the test tube is a old time test, and it is probably more so required for centers which do not ventilate, do not have CPAP. It is a sign that if there are no bubbles are formed on shake test, then you should refer this baby urgently to a center where CPAP facility and ventilation facility is available. So that is an important thing to know. Nasal CPAP is preferred modality to provide peak. This is a very simple method. You can see this is a baby in incubator, preterm baby in incubator, who is being getting this binasal prong CPAP. Recent large clinical trials show that giving early CPAP to babies even as preterm as 26 to 29 weeks gestation can be managed without intubation or surfactant about 50% of time. 50% is a huge number. So 50% time you can avoid intubation and surfactant. All come with such a huge cost. Intubation means having a separate tubing, surfactant cost 18,000, 20,000, 10,000 depending on which one we use. So if you give CPAP and can avoid it 50%, then half of your problem and family's problem is sorted as well. CDP or continuous descending pressure, which nasal CPAP provides, has several theoretical benefits, including splinting the upper airway. So not only it expands the lungs, but it expands and splints the upper airway as well, maintaining the lung expansion and preventing end expiratory alveolar collapse, thereby facilitating endogenous surfactant release and retaining it in the alveoli. So this is important, preventing end expiratory alveoli, because in inspiration, you are actively taking a deep breath. So alveoli, जब हम फूक मारते हैं गुब्बारे में, तो गुब्बारा फूलेगा ही. जब हम फूक मारना बंद करते हैं, and if there is nothing to stop, the air from coming out again, the balloon will collapse again. So if the balloon collapses, then during this expiratory period in which balloon collapses, blood supply is there would be a VQ mismatch. So this will lead to acidosis, hypoxemia, tissue level acidosis, tissue level hypoxia. So baby will start going down as well. So it was realized very early in 70s by Gregory et al. Who started this CPAP in 72, 73, that prevention of end expiratory alveolar collapse is the key physiological factor which CPAP provides, thereby facilitating endogenous surfactant release and retaining it in the alveoli. Because if hypoxia happens, if VQ mismatch happens, then the type 2 cells which produce surfactant, they are damaged serially with time, and surfactant production is reduced further. Nasal CPAP versus IMV in preterm infants at risk for or with established RDS without respiratory failure. Nasal CPAP is the initial preferred intervention versus combined regime of intubation, surfactant therapy, and mechanical ventilation. CPAP is more effective with lower mortality, combined death or mechanical ventilation, reduced need for BPD compared with intubation with or without surfactant therapy. So endotracheal tube डालना है, कम से एक एक्शन ओरिएंटेड चीज लगती है. सीपैप तो नर्स लगा देगी, तो लगता है कि कुछ किया ही नहीं हमने. Surfactant देके भी लगता है कि हाँ, we have done something. So masterly inactivity at times could be the best thing. We have heard that in obstetric parlance, masterly inactivity during the stage of labor, that you just wait and for the labor to progress. So masterly inactivity in RDS in NICU is something which is good. You just put the baby on CPAP and wait and watch clinically and biochemically on an X-ray wise. Don't be in a hurry to intubate. When to begin? How early is Dr. Akash? What is the timeline? I don't want to hurry into it.
You can take your time, sir.
We
Amit,
should have a timeline, and after that we should take questions.
Amit, you are
We
at a
can
good
have it in
pace.
two halves as well. What do you say, Dr. Somsekhar?
I think there are a few questions in between. I think we can answer them and then proceed.
Yes,
That
so
might be
let's
also a
take
good
up
idea.
let me have these few slides of CPAP and then we take
Ah,
few questions still over here
yeah,
and
yeah.
then we
Okay,
move
okay.
on. Otherwise,
Sure.
most of the lectures you see, a person
Mm.
talks and talks and talks and talks and people get bored out of that lectures.
No,
There,
no, that's fine. Yeah, you finish a few slides, then we'll take the questions
yes,
in
sir.
the chat box.
CPAP when to begin, how early is early? Initiation of CPAP from birth and delivery room rather than routine intubation for stabilization or prophylactic surfactant treatment is better at preventing lung injury. Although it is important to try to determine when CPAP alone is not going to be effective. So this we have discussed earlier. So this is where clinical acumen comes into picture. This is where AI will stop helping you, but your vast experience of seeing babies of so many years will help and say कि भाई ये बच्चा नहीं लगता कि ये चलेगा सीधा, इसको हमें जल्दी कर देना चाहिए वेंटिलेट, सो इसको हमें जल्दी सर्फेक्टेंट देना चाहिए. सो clinical sense for a doctor should never be left behind and it should always be carried in your pocket, in your brain all the time. Devices for CPAP, bubble CPAP um, is very good. And many companies are making it now. There must be, I think, more than 50 companies who are making bubble CPAP. Flow generator used to be there early on. Phoenix also had a flow generator. Infant flow driver used to be there when I was staying in Australia. Infant flow driver was used in babies who failed CPAP before you took on to intubating a baby. There seems to be no difference amongst devices used to deliver CPAP pressure, although the interface may be more important. So, जो डिवाइस आप दे रहे हो, if it is working properly, कई बार डिवाइस ही वर्क properly नहीं कर रही, तो then nothing can be done. So, uh, so you see CPAP interface is important. Nasal prong CPAP is important, but the best which is considered is binasal, short binasal prongs. और नाक में दोनों नॉस्ट्रल्स के अंदर ये जा रहे हो and not too long, just crossing the nares, that is good enough, and they should be more than 50% of each nostril should be covered with that. They are what you say, there are charts which you can use. You can put on the nostril and see which size will fit for this baby based on the size of the nares. So, how you drive your car is probably more important than which car you are driving. So, mastering what you have is best. Nurses also are very confident, and when they have to use the same machine all the time instead of you have 10 different machines. So, having one type machine, 10 units is probably better. So if I were to use, I most often use this binasal prong. In babies who have some injury on the nose, then we use this nasal mask, which are very soft and injuries are less common with that. And ram cannula is there. It's not there in this. That is something which is very exceedingly commonly used. There is a January again cannula which is there, which is a bit costlier, but it's wide bore as compared to ram cannula and better pressure delivery. Higher flow rates can be delivered on CPAP through ventilator on that. So how is CPAP through ventilator compared to CPAP through CPAP device or CPAP machine? They are equivalent. If you are using bubble CPAP, then many things are there in bubble CPAP which say that it's better than plain CPAP. And like ventilators, you advantage of using ventilator is that staff is very happy that you start with CPAP, switch on to ventilator if the baby needs it, extubate, and switch back to CPAP, and you don't have to change the machine, change the tubings. So it is equivalent. It depends on a number of ventilators which you have. So this is about CPAP, adjunct therapies later. Failure of CPAP, I can finish off. It is defined as pH below 7.2. So acidosis is happening. Acidosis is a surrogate marker for hypoxia. So इसलिए हम एबीजी देखते हैं, अगर एसिडोसिस हो रही है तो इसका मतलब हाइपोक्सिया हो रहा है. So if your FiO2 requirement is more than 40%, definitely if it is more than 60%. So if your FiO2 requirement is more than 60%, you can safely say that he is requiring probably more than CPAP and we need to intubate. CPAP failure increases with decreasing gestation age. So you can wait probably in a baby who is 30 weeker, you won't wait much. Whereas a baby who is 34, 35 weaker, who is on CPAP, you can give a bit of higher to look at the X-rays. But in a white out lung, you would switch over to surfactant therapy and intubation faster. Whereas if it's a, just a granular pattern which is there and more of a unilateral pattern is there, then you can say, okay, let's wait a bit more and see how we go forward. Causes of failure of CPAP, it's not just progression of disease. One has to know that the natural history of RDS is to progress in first 48 hours to 72 hours, then to stabilize by day 4 or so. Classical teaching used to be that diuresis is a marker of improvement in RDS that is about to come. So that led to many people using furosemide or Lasix as a treatment modality, only to fail very badly. So diuresis, if you have a good eye clinical sense and units are monitoring urine output well, then that still holds true. That if the diuresis has set in, then your turning around of RDS is also about to happen, and then you can wait a bit. CPAP failure increases by decreasing gestation. You should always, when a baby is having more distress, more acidosis, and you're likely to fail, then you should always rule out pulmonary air leaks, PDA, IVH, sepsis, and severe RDS. Sepsis means like congenital pneumonias could be there, and intraventricular hemorrhage, you can do cranial ultrasound, PDA by functional echo, and pulmonary air leak again by ultrasound or chest X-ray. Long-term outcomes of CPAP, CPAP is always better and long-term outcomes are very reassuring. So many trials have shown that it is now not even worth discussing that is it good enough in long term or not. Final word and caution, clinicians need to follow the criteria used for initiation and discontinuation of CPAP to avoid its overuse and minimize long-term safety. Nevertheless, CPAP remains the preferred intervention for management of neonatal RDS to the regime of endotracheal intubation and surfactant administration. CPAP on extubation, if you have intubated and now are about to extubate, then all VLBW babies should be extubated to CPAP. If the baby is on oxygen and has apnea, then also CPAP can be used. We can use later, HFNC we can use later, but now as a comparative, we can just have 5 minutes of, we wouldn't have more than this in this lecture. Heated humidified nasal cannula, HHFNC, is a very good device, and it's babies also like it, nurses like it a lot because of the soft silicone which is there, which is very friendly for the skin of the baby, and it is not, the nasal irritation is not there. Babies don't keep on crying because of it, as usually they do on CPAP. So humidified oxygen is being delivered, heated and humidified, whereas oxygen cannula delivers cold oxygen and non-oxygen. Heated humidified oxygen is given, and FiO2 can be modulated. So unlike nasal cannula, where it is difficult to modulate oxygen unless you are giving through blenders. Blender should have been there in that talk on nasal cannula, because all preterm babies less than 32 weeks of gestation should be given oxygen only through blenders. Now it has come in NRP guidelines as well.
Dr. Amit, I think we can stop sharing and we can go through some of
Yes,
the
sir. We can.
questions. Yeah.
This I would say just it is alternative to CPAP, but it should not be tried in babies who are less than 30 weeks of gestation. Thank you. And we would take the, how do we stop sharing? Let me stop
Yeah.
sharing.
Mm.
Yes.
Okay, thank you. Great talk, Dr. Amit. It's very nice, very practical, as Dr. Thapar says. So I'll just give, there are some comments, some questions. So I'll just put them to you and then you can just go ahead and speak about it. Dr. Thapa mentioned about TAPVC being similar to RDS. So you can
Dr.
make a few
Thapar has
points on that.
to answer his own questions. He's
No, I know, I
so
know, but he has,
difficult, so
no,
senior faculty. If they ask questions, that is very
no, he's made a few comments also. So maybe you
yes,
can
yes,
speak about it more in detail that way.
yes, sir. So I would like to see that.
TAPC, just talk about TAPC and being similar to RDS and what can
No, sir,
happen.
I couldn't get that. Can you please repeat it?
TAPVC can be similar to RDS radiologically. So you can, when the X-ray was being shown, he talked about TAPVC, total
TAPVC.
anomalous
Yes,
pulmonary. Yeah.
so rare diseases, when we talk about, you know, classical neonatology for, then, yes, if baby who has RDS is not responding to your standard treatment, then alternative things which should come into mind is TAPVC is one of them. And I distinctly remember at least three cases in which just based on clinical picture and his response, echo was normal. I went back to cardiologist and I said, recheck your echo. I think this is TAPVC based on X-ray, based on its clinical picture. She didn't even come to do a echo. She said, let me review the images which they store. And it is just a case of what your mind doesn't think, your eyes don't see. And she called back in 15 minutes and she said that I have reviewed the images and I agree that it looks like TAPVC. So you can manage it like TAPVC. So obviously, these whiteout lungs, the classical eight figure of eight it doesn't come so early. It is there only in supracardiac TAPVCs. So clinical course, I can remember at least 10 or 15 babies who have just not responded to first dose, second dose, third dose, fourth dose of surfactant. And so these have been the babies who have had thoracic masses. These are the babies who have had very bad congenital lung disease. These are the babies who have had congenital heart diseases. And so, yes, Dr. Thapar, I would
Yeah. So
agree.
the yeah. So what would be the most common DD for RDS? You mentioned a few most
Congenital
common one that
pneumonia. I would say
yes.
congenital pneumonia would be the most dreaded as well
Mm.
and most common as well. But TAPVC would be a distant second.
Yeah.
Severe TTN is another thing, which is asphyxia lung injury would be another thing. Asphyxia lung injury is not that uncommon.
Yeah.
Many babies I see are given surfactant because of white lung, which I think if there is history of parental asphyxia, just simply ventilate them for some time, and the lungs, it is more of a water which is there, and it disappears in 30 minutes time, and you have very clear lungs in some time after ventilation. So don't waste surfactant if you have history of, but again, it's again your clinical hunch. At times you feel that probably surfactant, if your lung oxygen requirement is only 30% on ventilator with white lungs, so then I would wait. If oxygen requirements are more, then I would err on side of giving surfactant.
So one other question, like a comment from me. I think over the last 16 years, we saw first HHFNC being used widely before evidence became available, and then more evidence is coming recently. Same with RAM cannula, which started, I think, around 10, 12 years back. And then, would you want to comment on three things? These are comments from the comments. RAM cannula, whether it can be used. Second,
RAM
delirium with.
cannula can be definitely be used, but I would say look at the size and you give more pressures if the baby is not behaving as well because transmission of pressure can be a bit low using RAM cannula. If RAM cannula is not working, try CPAP at times with the broad tubings. CPAP can be better off. If you don't have CPAP and you have to give it through the ventilator, then try January cannula, which has larger bore and is much better off. Only problem with January is it is a single use, and we hate things which are single use. It can't be ETO'd, it can't be autoclaved, and it just bursts in one or two ETO or autoclaving. So that's what general mentality is. We can't. हम अभी डिवाइडर क्रॉस करके भी नहीं जाना चाहते, हम चाहते हैं रॉन्ग साइड पे ही जाके जल्दी से थोड़ी दूर या घर मेरा मैं उसी पे चला सो
That's fine. That's culture. So, what about delirium CPAP with neopup?
Delivering CPAP is the standard of care. एनआरपी हमारे बहुत सारे यहाँ डॉक्टर ब्रिजेन बैठे हैं, डॉक्टर सोमशेखर हैं, वो एनआरपी के सारे इतने प्रोपेगेंड हैं, डॉक्टर हमारे थापर साहब हैं, इतनी एनआरपी की क्लासेस कराते हैं सब जगह। तो उसमें तो डायरेक्ट एल्गोरिदम में ही है, इफ ए बेबी हैज सैचुरेशन ऑक्सीजन हार्ट रेट मोर देन 100 एंड नो एपनिया, you look at respiratory distress, start CPAP.
Yeah, so a neopuff, if you can get blended humidified oxygen, which Dr. Amit mentioned previously, that would be good. So that's something which we should try and use. वो अभी इस एनआरपी में तो उन्होंने क्लियर कट लिखा है कि ब्लेंडेड ह्यूमिडिफाइड ऑक्सीजन यूज होना चाहिए। ब्लेंडेड तो पहले से था, ह्यूमिडिफाइड दे हैव एडेड सिग्निफिकेंटली बिकॉज इट improves your temperature. Dr. Brajendra has asked a question on he wants to do ultrasound in the instead of X-ray. वो बोल रहा है कि एक्सरे निकाल दो और अल्ट्रासाउंड मशीन लेके।
But you can if you're really highly trained. But if your X-ray is taking time, then you can, if you have ultrasound machine, what you have at hand to do it faster, probably I would go with that. RDS, most of the time people are not that trained in ultrasound. And people, मैं तो बहुत देखता हूँ, if I have a query in my mind कि RDS है कि नहीं है, then I ask for it. If the X-ray is not convincing, then I ask the person, I say कि okay, tell me, can we differentiate between say this pulmonary hemorrhage or RDS? Can we differentiate between hemorrhage and chronic pneumonia? And I don't get a clear answer in that. So, you know, clear lung will appear different from a white lung, whichever way you look at it. So you look by X-ray test, you look by chest X-ray or ultrasound. But if there is a gray zone, 30% HMD type is there, then so what your eyes are trained to, you do that.
Yeah, so ultrasound is a highly specialized skill. Not everyone is trained for it, and even people who do ultrasound themselves may not be very good in lung ultrasound. So that is something which is far ahead in the timeline, and in very few units will be able to do that, as you said. Uh, so Dr. Thapar has actually mentioned in the comments कि costly भी है, time भी लगता है. Uh, ये then there is something with nasal masks for CPAP.
Nasal masks are a good thing, very soft. अपना अलग जो नई कंपनीज की जो आ रहे हैं, they are quite good and it can definitely be used. My nasal
Doc-
prongs are probably better, but nasal prongs can be used, especially if you have trauma, or because nasal prongs will definitely cause. If nasal prongs have caused trauma, then shifting to nasal this mask will help.
Dr. Gurmit, I think, had asked a question which I think you explained, bubble CPAP or variable flow CPAP, which one is better? Did you? I thought you mentioned between bubble CPAP and ventilator CPAP, if I'm not
Yes.
wrong.
Variable flow CPAP is like duopap.
Yeah.
And duopap some machines are providing. And so if duopap CPAP, this we have to know which babies we are to use this beyond CPAP. So CPAP plus, I say, if a baby requires like he has FiO2 requirement of 50%, you are already CPAP of 8 or 9, you are already given. And babies at the cusp, if he doesn't have a white lung, he has reasonably expanded lungs. He doesn't have, what do you call that? Air bronchogram right till the end. And he's also on the cusp of, say, recovery, having third or fourth day. Then you can probably go on to the duopap or the variable flow CPAP. And so that is the role to be there. I often use duopap. I have a couple of machines for duopap, duo CPAP, in which, as per inspiratory time which you set, you give CPAP which is low, which is about 5 or 6, and you give a second high CPAP or BiPAP, as can be called in adults. We use it about 4 centimeters above. So 6 is low and 10 is usually which you give as the second thing. So that can be used. There are a couple of papers for that, and it can be tried. But these are all costly machines, and if we have it, then obviously they do help.
Okay. So one more question, which is there. This is related to Lasix. Dr. Jitendra has asked. I did not get what he mentioned. He says Lasix should not be
Elastics I
used.
had used once during the lecture, and only to say that it should not be used. And
Okay.
when we were doing our initial training, then surfactant was not in vogue still at that time, and we would see a classical course of RDS. And so, what would be a marker of X-rays also could not be done every 4 hours. Ultrasounds for lung were not there. So, looking at urine output was one important marker which was there. And I'm talking about late 90s and early 2000s. And so, when diuresis starts, that used to be the harbinger for improvement in respiratory status as well. So there was a study and there was a Cochrane as well on use of diuretic for improving outcomes in RDS. And it said that it doesn't benefit. In fact, it harms and it should not be used because, your electrolytes can get washed. Such a preterm babies, they don't have that sealing effect of furosemide. It doesn't have it's a non-sealing diuretic, which means that any amount of loss can happen with that. Even if baby is dehydrated, he can still keep on excreting more urine if you give furosemide, unlike say thiazides or aldactone, which are low ceiling diuretics. So furosemide should not be used unless you have significant edema. Then also treating the cause of edema would be more important, like sepsis and hypoalbuminemia, where albumin may help. Albumin followed by Lasix may help, but not plain Lasix.
Thank you. There are good many more questions. I think we'll just keep answering questions. More interesting. Dr. Jitendra has made a statement. Then I will add a question to that. HHFNC can be used as a primary therapy for RDS. My question is, there are three things: CPAP, NIPPV, and HHFNC. So which one would you want?
CPAP.
And CPAP. Why and why not HHFNC or
HFNC for more
NIPPV?
than 30 weaker, HFNC would be fine.
But your preferable one would be CPAP or HFNC?
CPAP. That's
I
what
think
most of
there's
the world is using. Americans, they use HFNC more often as compared to, so it is also where something has been brought up. And, but yes, HFNC in my unit, what do I follow? Whichever machine is available, they use it. They don't discriminate much. So same you can do. I don't even ask a question why we use this. But
yeah
yes,
there
if
are
a baby
th-
is, we are on the weaning side. Then or if a baby is on CPAP, we switch down to HFNC. If the baby is not doing well on HFNC, then we switch over to CPAP.
yeah I agree. So basically there are minor differences between them, but you prefer people, as you said earlier, that you should use the machines which are the most common and which you are most confident with rather than shifting between various machines. So, Dr. Shri makes a very good point, and which I agree with. Blenders are not there in delivery areas, which are the first thing to be done. So, in fact, I think IAP and NF for the NRP since 2010 or 11 has been saying that blenders should be there. It's almost 15, 16 years. So now it is up to every hospital or every obstetrician to ensure blenders are available. It costs around 80,000 to 1 lakh.
There is
So
no
I think it's
excuse
important.
of not having a blender. And
Yes.
so I would say that when we buy a ventilator, so would we have bought a ventilator without a blender, which you can't taper oxygen or increase or decrease, that. So hospitals, they can't hide behind, inadequate services, saying it is costly, and 80,000 is not a cost at all. And all private hospitals, they charge money, and they should spend it on the baby as well.
So
And
if
government hospitals also, it's not a time where, private medical colleges, and there is I see no reason other than, uh, I should not say that it is basically, it's a deficiency in service now if you don't use.
Yes. So I agree. So IPNNF has actually been many years. They have said कि blender होना चाहिए, saturation monitor होना चाहिए. It has de-emphasized the EEG, ECG, despite it being there in the US guidelines since 11 years, because we feel that it may not be too much of training is required. So even LMA has been there, but it is still de-emphasized. But blender has been like कि होना चाहिए, saturation monitor होना चाहिए. But if hospitals don't get, we can't do much. So it's up to their responsibility. So Dr. Shalini asks a
पेडियाट्रिशियन
very
को अपना लेके जाना चाहिए. मैं देखता हूँ जो
uh,
पल्मोनरी मेडिसिन वाला ना होता है, इफ यू कॉल
uh,
हिम फॉर अ विजिट, he would come with his own pulse oximeter in his pocket. So,
right.
because if it's not there in the ward, he would like to see what is the saturation of that adult with, COPD. So,
You want to talk about pulse oximeter? What? No, maybe we will not talk about it too much out of the way.
yes.
Uh, There is a question about should we wait for X-ray to make a diagnosis of RDS from Dr. Tripathi. Good question actually.
Yes,
So
so most of the time, even surfactant is not available right at birth. But definitely the answer is you don't need an X-ray to give surfactant. But on the other hand, I would like to confirm my diagnosis of RDS to know the severity of RDS. Knowing the severity is also important. I may be sure that this is RDS. It's a 30-weeker mother has not received antenatal steroids. He has significant retraction soon after birth, even if there was no asphyxia. And he cannot have anything else other than RDS. So it will be, even if he has congenital pneumonia, I will not be able to diagnose that, differentiate with from HMD by X-ray. So I have to give surfactant. But is it a white lung? What do I tell the family about the response to surfactant? कि क्या मुझे क्या लगता है? If it is a white lung, I would say कि यार बिल्कुल white lung है. Baby may not respond well to the first dose. You may require second dose. Whereas if it is a borderline case, I will say yeah, he should be fine with one dose of surfactant. You have to talk to family. And so I think it helps you not only in diagnosis, but also in prognosticating as well. So
yeah.
normally I would do it. Sometimes I am in a very proactive mode where I have, surfactant and everything available right at the parents' demand. डॉक्टर साहब कुछ भी हो जाए जो बेस्ट पॉसिबल चीज है वो चाहिए मेरे बच्चे को. Then
So
I have
I
surfactant 2 vials in the labor room itself कि अगर उसको बहुत डिस्ट्रेस रहा कुछ रहेगा, so we give that over there without X-ray as well.
So I would think that if there was no labor induced, there was a delivery, premature delivery, and steroids have not been given, then the most 32 weeker, 31 weeker, 33 weeker, the most likely diagnosis would be RDS. And I would probably, if the baby is distressed, I would start CPAP. And usually surfactant we would not give in the delivery room, but I think we can definitely start CPAP in the delivery room and shift the baby to an ICU. And for that, we may not want to wait for an X-ray. That we can do later. Is how I would look at it. Would you agree or would you want to do it differently, Dr. Amit? Dr. Amit? Acha.
Sir. Yes, sir.
Would you agree if there's a 31, 32 weeker who is distressed after delivery and there is history of no steroid being given and there was no long delivery process or labor. So most likely diagnosis will be RDS and I would probably start CPAP in the delivery room and shift, and then when time comes you can do an X-ray, not
Yes.
wait.
We
That
can
would
have
be
an
the
X-ray machine ready over there and it can be done pretty fast. Your systems have to be trained to be quick and it is possible.
so there are two, three
I
more
would
questions,
like
but
to have a pocket X-ray machine soon, like a CT scan, which can be just rolled into quickly and, like a stethoscope, it can be carried. And so that is the few of the innovations which I want so that we are not dependent upon radiologists or the technicians for the X-ray.
so I have a question, and that is related to one of the questions that they have asked. And they're complaining over residents. I don't know the residents are in the uh, audience, but they're saying that residents don't want to use Neopuff or don't know how to use Neopuff or it is
They
not being
don't know
utilized
it
properly.
because they have not been taught. That is so simple. I never
And no
knew to use ventilation before I went to a unit where there is ventilator and where
ventilation.
people are there to teach you ventilator.
So
So
other
नहीं जानना is only because किसी ने बताया नहीं है. जब उसे बता देंगे ट्रेन हो जाएगा वो जानने लगेगा.
so the other question is you mentioned in your lecture that you said you should have clinical sense. So my question is, how do you develop clinical sense?
That is the best question. देखो सर, हर शहर में एक डॉक्टर होता है who is said to be very famous, है ना?
Yeah, yeah.
And you wonder why is he so famous? And gradually with time you look at that person, look at the patients which he has seen, and he will have the knack of identifying complications earlier and which baby is going into, problems, he would identify that faster. And now that is something which is clinical sense. And that comes by having your mind and ears and eyes on functional mode all the time. Your concentration should be on the baby and you should be well read as well. If you have this combination of being well read, being having good concentration, Your mind is not diverted into different things कि अच्छा मुझे अब ये करना है, अच्छा वो भी है ये भी है. अच्छा डॉक्टर भी अगर उसका माइंड डाइवर्टेड है ना, he will make judgment in error. Whereas if you are full time, that is why it is said intensivist and OPD can't go together hand in hand. कि वो फोन पे जो है ना बात करके अच्छा पेशेंट का ये हो गया आपका तो अच्छा ये कर दो. So you can't do full justice to a sick baby like that. So good
Yeah. So
clinical sense के लिए बहुत सारे पेशेंट देखो और learn from that from every patient even if he dies. You learn from that patient. कि अच्छा, I remember babies who I have lost. I remember their colors. कि okay, how that baby looked pale. I couldn't recognize that that pallor is because of hypoxia. His saturations were good, but tissue level hypoxia must have been there. That baby had RDS, which was worsening. Those were the early days of surfactant, and it was not very commonly that I could get surfactant from there, and we lost that baby. I was doing my TN. There was a very senior person who was MD on my duty at that time. And so you keep on. Death should be analyzed, even if your HOD is not doing it, you analyze all deaths. You analyze what went wrong at each step, and you get wiser in the next.
so
That
the
nothing is
point,
more than
yeah.
hard work is required, dedication is required, and to develop this common sense.
So
Common
the
sense has to be earned and learned. It
yeah,
doesn't come
true.
very commonly.
So the reason I asked is because there are often complaints and people want to do less work or कि ये मेरा काम नहीं है. तो often I tell residents कि what you do now is going to define your life forever. If you बाद में करेंगे, बाद में सीखेंगे,
आई
वो
थिंक
कभी
सर
नहीं होने वाला है.
रेजिडेंसी की ड्यूरेशन जो है वो 3 साल की, उसके काम कम
हाँ.
करके उसको 4 साल या 5 साल कर देना चाहिए,
हाँ.
और या 6 साल कर देना चाहिए. एंड उससे आपके पास कम रहे, वो फैमिली भी देखता रहे, स्ट्रेस भी कम ले, बट ड्यूरेशन तो उसको चाहिए रहे.
हाँ, चाहिए चाहिए.
प्रॉब्लम विद आर रेजिडेंसी इज हम
हाँ.
हम डिफरेंशिएट नहीं करते कि कब लेवल 1. अब जब रेजिडेंट फर्स्ट ईयर का रेजिडेंट आता है, उसको मन में रहता है मैं सेंट्रल लाइन डालूं, मन में रहता है मैं वेंटिलेट करूं, मन में रहता है मैं सर्फेक्टेंट दूं, है ना. वेन कहीं भी इंटरनेशनली मैं इतनी जगह मैंने काम कर रखा है, फर्स्ट 3 years यू नेवर गो टू इवन आईसीयू. आईसीयू go only when you decide that you are going to be full time intensivist, and then you go into ICU. ठीक है. सो हम
So,
लोग के पास बहुत स्ट्रेस रहता है रेजिडेंट के ऊपर कि ये
हाँ,
सारी चीजें हैं, उसको ड्यूरेशन बढ़ा देना चाहिए और टाइम कम कर
ठीक
दो.
है. Okay, I think we are getting out of the topic, so now we'll come back. And do you want to finish off a few slides more, Dr. Akash?
No,
What should
sir.
we do?
We, we,
We're at
we, we should finish over here.
हाँ,
It's a good 1 hour plus, and
या
good
अच्छा हुआ है
session.
लंबा.
Good questions were there. I was very happy
I,
to answer them. And with
I
you
hope.
as a, क्या है, कृष्ण जी.
So the last question is there. Last question is there. What about the use of conventional bubble CPAP? I don't know why this was asked because you mentioned it, if I'm not wrong.
क्या क्या सर, मेरे को क्वेश्चन नहीं सुनाई दिया.
What about the use of conventional bubble CPAP? ये question क्यों आया मुझे समझ
Conventional
में नहीं
bubble
आया.
CPAP has to be used. It is not gone out of vogue, and you have and you use it. It is fine.
Okay, as I understand, because this is a UP session, most of the SNCs in UP have been, I think, have received CPAP machines, and there is ongoing CPAP training in UP SNC, is
Yes,
what
sir.
I understand over the last year. That is not in every state, but this has happened in UP. And I had a few questions, and I thank you for two things. One, you mentioned about dexamethasone or betamethasone, जो अभी भी काफी some gynecologists are not following in India, which was very surprising to me, and the grunting, which ensures that you have to start CPAP. Uh, I have already asked you a question, which I mentioned.
Dr.
Yeah,
Shalini
I think,
Tripathi has mentioned ET CPAP not to be used. Definitely, it is not to be used. And
yeah.
ET CPAP in preterm, especially, should never be used. It's a good point. It's a good thing to point out, Dr. Shalini. Thank you. Uh,
I think we have completed most of the questions. And thank you very much, everyone, for the engagement, discussions, and the questions. We all more wiser about for it.
but
And so
try to keep it clinical so that we
yeah,
just don't go on theory and
yeah.
um,
So one more, I have a request, and on 10th May we have a NRP day that we're planning. So if you are able to organize basic NRP, sessions in your respective hospitals. It would be great. You can get in touch with Dr. Amit, Dr. Lalan, or me if you want
Yes.
to organize
A
on
lot of
that day.
meetings
So
are going on for that, sir.
yeah.
Dr. Vijayendra is here, Dr. Apna Thapar is here, and
So
many people are already into it.
So you're planning to have at least 4,500 people trained on one day on 10th May. So if you are able to manage mannequins, etc., on your own in your own medical college, please get in touch with Dr. Brajendra for UP. And for anywhere else, you can get in touch with me, Amit, or Dr. Lalan. Thank you. Dr. Akash, back to you.
Thank you so much, Shikhar sir, for moderating the session. Thank you, Amit sir,
Thank you,
for
sir.
making it practical, interactive, and a useful session for everyone.
All right. Thank you.
Okay,
Thank
good
you.
night,
Bye, bye,
everybody.
bye. Bye. Good night. Bye.
Bye-bye.